Hello. In this screencast, I'm going to look at the coagulation practical. Now, apologies ahead of time if the recording audio is a bit funny and you're picking up a lot of background noise from my dogs and my kids. If you've seen the post on the ED discussion board, Luna ate my headphones, and so I'm using a new pair. And I'm actually finding it really weird because it's changing the way I sound and it's picking up a lot of background noise. So hopefully I'll get this fixed in the coming days, but I really wanted to get this screencast out to you. So when we're looking at the first activity, a lot of this is a sort of knowledge that I hope that you would bring forward from Haematology 1. And so to complete this activity, if it's not fresh in your mind or you can't really remember or you didn't listen to COAGs, I suggest you go to the pre-labs that we have. So let me just bring this up. So our pre-lab here in our UTS Online, so this was I think pre-lab 4. And so we have the information here in the pre-labs. We're looking at our PT. Our PT is our extrinsic pathway, and it's used to monitor the warfarin therapy. Pretty much it only has factor 7 involved there in the PT. So the normal range is 12 to 16 seconds. So a factor 7 deficiency is clinically when it is raised. Liver disease is also when it is raised, or vitamin K deficiency. We do see that happening there as well. And the drug that we see is warfarin. So if you think about rat poisoning, it's a super warfarin. And so sometimes with people who have PTs that we just cannot sort of get an endpoint to, sometimes we see that in rat poisoning when they've accidentally ingested rat poisoning. So the next one I want to have a look at is the APTT. So the APTT is a measure of the intrinsic pathway, and in a clinical setting it is used to measure heparin. And so it is a factor of the other factors other than 7, but most importantly your 8s and your 9s, so your hemophilia. Normal time is 25-35 seconds. So looking at factor 8 or 9 there clinically, and we're looking for heparin when we're looking at as what is clinically causing, or what sort of drug is causing an increased time there. Also in your PRAC manual, though the PRAC is slightly different, you will have some of the new oral anticoagulants listed there, and you could have a look at that as well. So when we're looking at the thrombin time, it's a test of your common pathway. So what we're looking at here is it indicates a fibrinogen deficiency as the clinical cause, and any overuse of any of the other anticoagulants, in particular your heparin or your dabigatran. So what are your DOACs? This isn't really covered in this PRAC anymore, but it is important because if you go work in a lab, everyone's on a DOAC nowadays. So people used to be on warfarin, particularly if they had presented with arterial fibrillation and wanted to be put on blood thinners. But now they are on DOACs, because with the warfarin, you used to have to get your INR taken and have a look at that to make sure you're on a right dose, but you don't have to sort of have that continuously monitoring with the DOAC. However, they are mostly irreversible. So they are used with venous thromboembolism to prevent stroke. So with this sort of information, and there's actually quite a bit more information available for you, such as the D-dimer test, and then in your pre-lab, your different cells like your megakaryocytes and your abnormal platelet numbers. So do make sure that you look at that. And then there are some disease states as well, such as ET. We haven't quite covered that. That will be in Susan's lecture. So do go through your pre-lab slides here, and a lot of those first few parts can be filled out with that information. So going back to our document here, so that's activity 1, and most of activity 2 can be done by that as well. So then we come to activity 3. So the first, with activity 3, I want you to look at the plasmic score, and that's because I want to start to really get you in tune with what is critical in a hematology lab. What are the sort of things people panic about? What are the things you must know at an interview? And one of those is TTP. And again, it's life-threatening, and that's why it's really important, because you're the only person there in the lab overnight. It's up to you to find the TTP. So if the patient does have TTP, then we need to get them plasmapheresed. So they have that Adams TS antibody, Adams TS13 antibody. We need to remove that plasma and remove that antibody so that they stop making these clots in their microcirculation. However, just because someone comes in the middle of the night with a low platelet count does not mean that it is obviously TTP. Running the Adams TS13 antibody is quite expensive. So we want to put it in a way that limits the clinician from ordering this unnecessarily and actually not going down the road of TTP when it's not likely. And so that's why they've come up with the plasmic score. So let's have a look at the first example. So the first one I kind of made up on the spot, and that's why some of the things aren't there for the plasmic score. So a 14-year-old male who presents to emergency with recurrent nosebleeds. The patient does not have a fever or any other concerning symptoms or any previous medical history other than recurring nosebleeds. His biochemistry results are normal. His hemolysis screen was negative. So if you remember back to practical 1, we talked about what sort of tests are in a hemolysis screen. His full blood count and coagulation screen is ordered and the following results are obtained. So the first thing I do is I look at his full blood count results, and I know that that is normal overall apart from that platelet count of 45. That's a critical platelet count. And I'm looking over at his coagulation results. Now the INR is taken from the PT, and that was something we looked at in Hematology 1, and so my PT is normal, so I pretty much think there that my INR is going to be pretty normal as well. The one thing I am picking up is some abnormal platelet function studies. So not only do I have an abnormal number in platelet, I now have platelet function that is abnormal as well. So we want to go open our plasmic score. So let's have a look at our plasmic score and what's going on with our plasmic score. So did I have a platelet count less than 30? No, I did not. So I leave that on no. Did I have any signs of hemolysis? No, I did not. My biochemistry was normal. Did I have active cancer? That is no. And one of the things, so did I, yes. So I suppose that you just want to make sure that the TTP isn't, or the fragmentation isn't caused by some sort of malignancy or some sort of cancer treatment or a low platelet count. So what we have now is a platelet count that is not caused by chemotherapy. Do we have a history of a solid organ or stem cell transplant? No, we do not. So again, the results we have are not accounted for by that. Is our MCV less than 90 femtoliters? Yes, it was. Was our INR less than 1.5? So 1.5 is the normal range. So yes, I do have that there. And is the creatinine, my creatinine was normal. So I have a plasmic score of 4, which makes him a low risk and pretty much 0% risk of Adams TS13 deficiency. So what this is telling me is I do not have Adams TS13 as a likely diagnosis in this patient. This patient is unlikely to have TTP. So we're going to look down at our picture. And what I want you to note is the presence of large platelets. So these aren't platelet clumps, they are one platelet, and they are a large platelet. And so we have now 2 things that could be going on here. One, it might actually not be a platelet count of 45, it could be slightly higher. So we need to think back to Hematology 1 with our impedance and optical platelet counts. Are these large platelets being gated in with the platelets? However, I do think that this person probably does have a low platelet count, but definitely not at that critical level of 30 that we see in a TTP. We have a low platelet count, and the vast majority of these cells are large platelets. So when we looked at Dollar bodies back in Hematology 1, we looked at May-Hegland, so a disorder where people had large platelets and they had Dollar bodies in their neutrophils. I don't have Dollar bodies here in my neutrophils. So I have large platelets, I have a low number of these platelets, and these platelets are functioning abnormally. So what you need to do is go through your lecture and have a look at sort of what's happening there. So what was the plasmic score? Was 4. Do you suspect this patient has TTP? No. What is the defining feature of our TTP? Schistocytes, fragments, and low platelets. So I have low platelets, but I don't have critically low platelets, and I definitely have no schistocytes in that picture. So it is not a TTP picture. What is a likely diagnosis? When we start looking at the abnormal coagulation results with the large platelets, we want to come across some of these platelet disorders, and this is consistent with Bernard-Soulier syndrome. So the next one was a case study, and you could have read the whole journal article if you wanted to have a look at it. We had a previously healthy man in his 70s with acute headaches. He had a 1-year history of dizziness, platelet count of 20, creatinine was abnormal, LDH biochemistry was abnormal, signs of hemolysis. His peripheral blood sphere showed the schistocytes. So from that, you should have been able to figure out his plasma score, and it was quite likely that he had TTP. Wasn't 100%, I think it turned out to be about 70% chance. So what we would do there, at that sort of stage of likelihood, we would run that Adams TS13 antibody test, and that would give us that confirmation that this was driven by TTP. When we're looking at the third example, we have a patient that had oncology, so that platelet count could be caused by the chemotherapy, and that's why the doctor could be concerned. They could be concerned the patient has TTP because low platelets sort of panics everyone. However, the coagulation results were normal, the biochemistry was normal, everything else, the full blood count was normal, but a platelet count of 3. So we would do an urgent blood film before we accept that result. And if we saw this, well, I can see there's more than 3 platelets there. And so what this platelet patient has is platelet satellitism. So the platelets, due to an EDTA interaction, are going around the neutrophils. And so therefore, they're not going to be going through the impedance count for platelets. Even the other ones are clumps, so they're not going through an impedance count for platelets. And only the ones that are singular are being counted as platelets. So the platelet count is wrong. We do not trust this platelet count. In fact, we would not release this platelet count. The platelet count is wrong. We'd probably release that it's clumped normal because there is a normal amount of platelets there. If they were to have spread out in their own space, we would have plenty of platelets there. So you can figure out the plasmic score for this patient. It will be quite low, although that platelet count of 3 will trigger it being higher. But if you had looked at the film, you would know that that was incorrect and you couldn't rely on that platelet count. There's no schistocytes. I do not believe this patient has TTP. There is not a true critical low platelet count. There is no presence of schistocytes. The low platelet is counted by the platelet satellitism, and my advice would be to not collect this patient's blood in EDTA, but to collect this patient's blood in citrate and run it for the platelet count on citrate, where you will not have this reaction with the EDTA giving you this result, and you'll be able to get the true platelet count for the patient.